All right, welcome everyone. My name is Dr. Michelle Immels, and I am the director of our Caregiver Live Well program, and I will be moderating our presentation today. It looks like we have both of our presenters with us, and they will be presenting on COVID-19 long haulers, post-acute COVID-19 hospitalized and not hospitalized. And so I'd like to give a little background on both of our presenters. Dr. Dixie Harris is a pulmonary critical care doctor at Intermountain Healthcare. Her outpatient clinic is AltaView Specialty Clinic, and she also works at UVRMC ICU and at Intermountain Telecritical Care. After returning from New York with the Intermountain COVID-19 response in May, she started seeing patients in clinic that continued to have ongoing symptoms from their COVID-19 infection. As more patients presented, she developed a special interest in learning about chronic COVID, as well as helped develop the treatment guidelines for chronic COVID for Intermountain Primary Care. Welcome, Dr. Harris. And Dr. Liz Joy is also joining us to present today, and she is a family medicine and sports medicine physician and Intermountain Senior Medical Director for Wellness and Nutrition. She sees patients at the Salt Lake Clinic Live Well Center and believes that healthy lifestyle behaviors serve as both prevention and cure for most everything. So I'd like to welcome our two presenters, and just a reminder that all of you have been muted on entry, and if you have any questions, please type those in the chat, and I will be moderating and asking those questions for you. And Dr. Harris and Dr. Joy will begin presenting, and I have Dr. Harris with control, but if Dr. Joy would like control of the screen, I can switch that over. It looks like only one of you can be presenter at a time. So just let me know which one of you would prefer to have that.
Oh, this is Dr. Harris. I can take control.
Great. Well, welcome to both of you, and we're excited to get started.
Okay. Can you hear me okay?
Yes, definitely can. Thank you for joining us.
Okay, thank you. Okay, so I'm Dr. Harris, and Dr. Joy, say hello.
Hello.
Yeah, so she's here with us. And I'm going to get going. I'm just going to do an overview of what I see long haulers are, and then Liz will come in at the end. And then just a heads up, I also have a lot of resources at the very end that we won't go over, but it's available. I don't know how you guys, I presume you guys share the slides, so they're just my personal notes, and anybody can use them in what we're using in clinic. So I think we have 30 minutes. Is that correct?
Yes.
Okay.
Yes.
I will be quick. Okay. So let me figure out how to run my screen. How do I run the screen?
I think if you click up above, do you see where it's there's an arrow next to the one and it clicks to the next? I just clicked it for you. Up above.
I see that. Gotcha. Okay. Thank you.
Yep.
So I just thought I added mine, and obviously Liz has added her Live Well. I have no disclosures, and she has no disclosures. So we'll get going. This is my first introduction into a long hauler. He's a 58-year-old male who was actually one of our very first COVID patients in Utah. He presented in March and basically was just put on some oxygen as an outpatient, was never given any medications. Week 8, he actually presented to the hospital with ongoing fevers, been having fevers on and off, but worsening after about 7 or 8 weeks, with chills, coughing. We hospitalized him for a few days. I was actually covering telecritical care and working with tele-ID. We really didn't know what to do with this gentleman. As you can see, he had multiple PCRs that were negative. And by week 12, he continued to have ongoing fevers. So I went ahead and did a bronchoscopy, and I didn't have anything growing. Week 14, he was still having fever, shortness of breath, a lot of systemic symptoms. And then week 16, he had connections, so I went down to UCSD And their ID people said, basically, this is kind of what we're seeing, continuous supportive care. By week 22, he was much better. He had mostly gotten off oxygen. By week 27, he called me up and said, I'm now having dizzy spells when I bend over, moving quickly. So the point of it is he continued to have ongoing symptoms, and actually the symptoms varied throughout. He was able to get back to work after about a month, so he wasn't off work that long. What I'm showing here is the CT scans, and we didn't have a CT scan when he first was diagnosed, but let me just kind of point to you the findings. Obviously, we're looking up at the chest, the heart, above the heart is right here. And you can see kind of these subtle patchy infiltrates. Down here, I'm just putting my arrows on them. But this is remarkable for viral pneumonia to still have abnormalities 8 weeks later. By 8 weeks, even a bacterial pneumonia should mostly be gone. And then again, at 13 weeks, there's still some subtle findings. So pretty much a gentleman that's had really a mild case, treated as outpatient, but even 13 weeks later had findings of COVID, and many, many weeks later had ongoing symptoms. This is just a screenshot. This is an early picture I've got. I believe this article was in June, but the point of this is just to point out this virus goes basically, I say tongue-in-cheek, the virus goes to wherever there are blood vessels, but in truth, we're seeing effects of the virus in many, many different organ systems. I want to point out that we've had a couple of other bad coronaviruses, and one of them's MERS and the other one's SARS, and now we call it SARS-1. But both of these viruses have been studied over the years, and they both have caused chronic fatigue, PTSD, psych problems, a lot of symptoms that have lasted years. The MERS have been studied. There was a paper 4 years later, patients are still having symptoms. Fauci made this call back in July when he was presenting at the International AIDS Conference. So this is something we've kind of been expecting to see. I'm just going to want to show you just a few charts just to show you the prevalence. And what I really focused on here was the non-hospitalized group. These are non-hospitalized university students. They're following post-COVID symptoms, and these kids were having symptoms 3-4 weeks later, and the light green is the symptoms that are ongoing. So as you can see, actually the fatigue was more prevalent after weeks than initially. So post-COVID and then recovered, again, we're still having symptoms even weeks and weeks later. The point of this slide is healthy young people can still have symptoms, and a fair percentage of symptoms. This was kind of neat. When COVID hit the Faroe Islands, and I don't know if anybody's ever been there, I didn't even know where they are, so I gave you a little map. But it's a very small island with a very small number of people, very small population. What they did is every COVID case they have followed and continue to follow. This is the longest chronic data. Very few of these patients that they followed actually were hospitalized. So we've got 125-day data on symptoms, and these are patients reporting acute symptoms and then chronic. And as you can see, the chronic symptoms more prevalent in the 35 to 49 and 50 plus. But the point of this is many days. I mean, this is 4 months. They are seeing symptoms post-COVID going on. I'm just going to spend a little time on this chart, and this is probably one of the best good charts of long-term effects of COVID. And this down here is the symptoms, and it's kind of upside down. So the most predominant symptom is fatigue, but it is shown in a bubble chart, and the bigger the bubble, the higher the percent of patients that have reported these symptoms. And this is the symptoms. This is a meta-analysis. They included 15 articles. They'd have 100 or more patients, and the symptoms had to be present for more than 2 weeks. So the top symptoms, and this is what we're going to be seeing, all of us are seeing. In fact, I referred somebody today to Live Well. Fatigue is the most prominent, headaches, attention disorder. I mean, a lot of patients call this like brain fog is what they're describing. Hair loss is a pretty prominent one, and then shortness of breath. And this is the reference. So if you want to spend some time looking at this, I really like kind of like the overall view of kind of all the different body systems that are involved with chronic COVID. This is a Facebook group out of the Netherlands, and some of them actually didn't have a confirmed COVID diagnosis, and a lot of the long hauler Facebook groups, not all the people have confirmed cases. But again, this group, a very small percent were hospitalized. But the big key on this group is before they became infected, 85% actually were in good health status, felt great. This is 79 days later, okay? So almost 3 months, and a lot of these patients who felt good prior are still not feeling great. They wouldn't describe their health status as good, and then even some of these have moved into the poor health. So the point being is, and again, this is a selected group that are having symptoms, but again, many of these patients are not feeling back to normal more than 2 months later. Johns Hopkins has published their data on how they put together a post-acute team. I really like this graphic. They don't have a number on the time. They don't have a number on the symptoms, but it just kind of like is an overview. I mean, there's certainly a group of patients that are hospitalized and even in the ICU. That's group number one. And some of these patients will continue to have ongoing symptoms. Again, another group is hospitalized but never hit the ICU. And again, some of them have ongoing symptoms. And then even the non-hospitalized patients have ongoing symptoms. Again, we don't know the percentages. I do know there's higher percentage of the patients with ongoing symptoms that were hospitalized and in the ICU than these. We're thinking it's 10, maybe 20% of outpatients are having ongoing symptoms. That's still not clear yet. What I want to just show you with this is kind of an overview of how they design their post-acute team and really kind of working with multiple specialties, working with primary care, a lot of interlinking between the specialties and the clinics. They don't have a Live Well clinic, I guess. Theirs is mostly run through pulmonary, but again, as you can see, all the different specialties that are involved in what they consider their post-acute clinic. We are working on developing one here at Intermountain. I'm also in talks and working closely with the U of U and a post-acute clinic also. So currently Utah doesn't have one. I just want to highlight, when I'm seeing these patients, I'm more interested, do they have delayed PEs or are they getting subsequent pneumonias? The pneumonias are very unusual, so we don't see a lot of that. Worry about pulmonary hypertension and then even CTEP and then pneumothoraces. I just took care of somebody that was at Utah Valley who was treated as an outpatient with COVID early December. He presented to the emergency room in Delta with bilateral pneumothoraces after a coughing spell. So needless to say, he had bilateral chest tubes and was flown to Utah Valley. Cardiac, obviously the myocarditis, the MIs. What we're seeing is some delayed cardiomyopathy. So somebody will be fine. They will be treated as an outpatient or even inpatient, and maybe a month and a half later, that will show up. Neurologic, to me, this is the most worrisome thing is the memory loss, brain fog. I was just talking to a gentleman today who works from home. He was hospitalized and intubated in July. He continues to have brain fog, and he's found that if he works too long on the computer, that the headaches come and he really cannot concentrate with what he's doing. And, I really encouraged him, spend as much time on the weekends and off screens as you possibly can. And then we definitely have some ongoing psych issues. What I'm really worried about with that group is people who need to have escalation of care with depression, PTSD, and anxiety beyond my skill set. So those are the areas that I'm real worried about. And then so here's my summary slide, and then Liz will step in. Basically, the prolonged symptoms are common, 10 to 50%. It depends on what study. That'll shake out, and we'll really understand that better. Post-ICU syndromes can certainly happen in our patients who've been hospitalized and in the ICU. That's a separate entity, but it's confounded by these chronic symptoms of COVID-19. And then my recommendation is to develop guidelines and more of a multi-system, multi-specialty approach. And in my opinion, when I see these patients in clinic, a lot of it is validating, yes, this is taking a long time. Yes, you eventually get better. It's what we've seen. It's really kind of a sad disease, but just telling them, yes, this makes sense and this is consistent with what I've seen, really empowers the patients that they will get better and kind of changes their attitude. And then all the different referrals, and I kind of listed several there. And I'm going to let Liz take over now.
Thanks, Dixie. And I just have a couple of slides to share, and then I'm going to turn it back over to Dixie, and she'll show some of the other materials that she's going to be provided this evening, and will be eventually on our Healthy at Home website. But this graphic really shows how people, who may be affected with long COVID symptoms, can access resources that are available through health promotion and wellness in our live well centers. And just, as an overview, we actually have 5 live well centers, but currently only 4 of them are staffed by a provider. So we have a live well center at Salt Lake Clinic, which is where I am right now, at the Park City Hospital, at the Utah Valley Hospital, and St. George Hospital. And patients, with long COVID symptoms may be coming from lots of different places. Pulmonary clinic, like Dr. Harris's clinic, from our primary care colleagues. And then several patients are self-referring, because they are learning, particularly on some of these COVID Facebook pages, that a lot of the interventions for these lingering post-COVID-19 symptoms can be addressed through diet and physical activity, maybe some supplements, perhaps medications, and they are seeking that type of care, sometimes because they sought care with a primary care physician, and felt like, this is not making me feel better, it's not what I'm needing. But, should a patient be referred to the live well center, with post-COVID symptoms, they're going to undergo an assessment with a lifestyle medicine physician or one of our advanced practice providers who is going to perform, an assessment, order additional labs and tests that may be indicated, may prescribe medications or supplements if necessary, and then can connect the patient with additional live well center resources based on their needs. And that's a really important part of this, is that within the live well centers, we have a wide variety of services in addition to some programming that's not necessarily germane to tonight's discussion, but we have registered dietitians, who can address some of the nutritional consequences. So what we're observing with some of these patients is that the altered smell and taste is decreasing their appetite, and they're actually experiencing weight loss as a result of that, which in turn contributes to their fatigue and the brain fog. And they may not even notice that they're losing weight because they just have less of an appetite as a result of the persistent loss of smell and taste. And then we also have exercise physiologists, within the live well centers who would perform a functional fitness assessment, determine where that patient is right now in terms of their ability to do any type of physical activity. And it really exists on a spectrum. Some patients find that they're struggling just to get through their activities of daily living. And then there are people who are dependent on active transportation. They're walking to the bus, walking to the train, riding their bike, and they're finding that their ability to actually, go from place A to place B, is impaired by, again, these persistent symptoms, which may be not only the fatigue, but maybe muscle pain or joint pain. An exercise physiologist, can work with the patient to prescribe, a personalized exercise prescription. And for some patients, that may actually be a covered benefit with their insurance. And for others, it's a relatively small charge of about $49. We have a very robust mindfulness and stress management program. And Dixie alluded to the fact that, these patients, experience anxiety and depression and post-traumatic stress, sometimes as a result of the infection, sometimes as a result of their ICU stay, and likely, all of the above. And, some may say, well, maybe I have a relationship with a mental health provider who I'm going to reconnect with. But for some, just teaching them breathing exercises, and connecting them with mindfulness resources, whether it's attending a class, many of which are free of charge, through the Intermountain Healthy at Home website, or connecting them with one of the mindfulness apps like Calm or Headspace. I find those to be incredibly helpful. And then, again, as Dixie pointed out, we know that, COVID affects nearly every system of the body, and sleep is one of those areas. Patients have trouble with insomnia. They may have nightmares or night terrors. It can disrupt their sleep hygiene. And we're very fortunate at Intermountain to have one of the state's 2 sleep psychologists, Dr. Lori Nealman, who works with the LiveWell centers and is providing virtual sleep psychology care. And she is a phenomenal resource. Dr. Lori Nealman is wonderful and really can help patients who are struggling with sleep. And again, when you're not sleeping well, you're not thermoregulating well and contributes to that temperature dysregulation that they experience. When you're not sleeping well, it contributes to fatigue and brain fog, and in turn, depression, anxiety. So you can see where all these symptoms start to kind of blend together. Let's go to the next slide, Dixie.
Gotcha.
So, when a patient presents to the LiveWell Center for lifestyle assessment and treatment, I just wanted to give you a sense of what that might look like. And I've kind of talked a little bit about what that lifestyle medicine assessment includes. It's a subjective symptom assessment. So what is the patient experiencing? Obviously, performing a physical exam. Dixie will talk a little bit more about some of the questionnaires, that could be used, some of which are COVID specific. Again, trying to elucidate some of the symptoms that they're experiencing in the past and currently. Certainly doing some mental health questionnaires, whether that's a PHQ-9 or a GAD-7, which addresses anxiety, and then also lifestyle questionnaires. Again, we may order labs and tests and referrals as necessary. I mean, certainly if we're seeing somebody who is presenting with very concerning symptoms for some of those conditions that Dixie referenced, whether it's, a pulmonary embolism or, inflammation around the heart or, concern over, a problem in the brain, obviously we're going to refer for that. And treatment in the LiveWell Center, definitely takes advantage, of the various disciplines that provide care there. So, nutritional interventions may include the use of vitamins and minerals. Recently, one of our family physicians had reached out to me, and I recommended an anti-inflammatory diet to her patient by, eliminating gluten, no added sugar, eliminating alcohol. The patient came back 2 weeks later and felt remarkably better, having really made some changes to her diet. There are supplements that are largely discussed on the COVID Facebook pages, which I keep an eye on because those are, the boots on the ground people who are experiencing this and using a variety of dietary supplements like ginger and turmeric and omega-3 fatty acids. In regard to physical activity, I'll just say, what we hear and what we recommend is doing something is better than nothing, but you don't want to do too much, so you kind of exceed that fatigue threshold. I've talked about sleep psychology and sleep hygiene, as well as mindfulness, and some of that is just that validation that Dixie talked about, that life is different right now. It doesn't mean it's going to stay different, but it's different right now, and really validating that is important. And then certainly there are times when, prescribing medications or supplements may be appropriate, whether that's for the patient with fatigue, somebody with mental health concerns and is presenting with, functionally impairing depression, anxiety, or post-traumatic stress. There are medications and supplements that we use for fever, muscle and joint achiness, likewise for insomnia or nightmares associated with PTSD, medications for neuropathy, zinc perhaps for altered taste, although an article that recently was published said maybe that doesn't work so well in the COVID-19 patient with altered taste, hair loss, and POTS for the people who may not be fully medical on the call this evening is postural orthostatic tachycardia syndrome, and that's when people are getting alterations in their heart rate when they stand up, or feeling dizzy or lightheaded. It goes along with fatigue, and there are again both supplements, medications, and lifestyle interventions that can treat those symptoms as well. So lots that can be done in that health promotion and wellness space to help people with these long COVID symptoms recover and function at a higher level. Dixie, I'll turn it over to you.
Okay. I think that's a whole lot of things that you guys can do. And actually, all of this is what I really promote. Even the patients who are coming in with chronic PEs from that. So I'm very excited to have this whole treatment approach offered to the patients. I'm just going to quickly show you some of my materials. And a lot of these are just mine and what I've gathered. It's not set in stone. But we'll go back to questions. I have a nice reference list. These are kind of some of the better articles, and are kind of in what I've collected. I liked this one. This was very good on the Mayo Clinic podcast. And then this is my questionnaire. So I like to do from when they started to the day I'm seeing them. And even if they've lost 2 symptoms, gone away, it makes them feel better. And then I'm doing the post-COVID functional scale. This is through the American Thoracic Society. And then I just give them instructions. A lot of what you guys are doing through the Live Well arenas, this is some of the things. And I just kind of set expectations and then give them techniques. I really try to stay with better resources, so stay with WebMD. But you're welcome to use this. Again, I don't pretend that this is the best thing, but it's, I try to give people something that they can hold on to. I know that Dr. Hirschberg, with her post-ICU syndrome, she likes them to journal a lot, and that's actually in my recommendation. And that actually helps the patients see progress. And I tell them the progress is more week to week, month to month, not day to day. So, any questions?
Well, thank you so much for sharing all of that. That was really, really informative. And we did have one question, and I know the answer to this, but I think I'll let one of you answer. I think more, Liz, it's maybe pointed to you in the Live Well centers, if I'm understanding the question from Josh correctly, are these treatments available to non-COVID patients? So I think he's referring to all of the different things that you had listed there at the Live Well centers. And if I'm not correct, Josh, why don't you type that in there? But that's how I'm interpreting that question.
Well, yes, I'm happy to take that. And in answer to the question, yeah, all of those services are available within our Live Well centers, and even more. Those are the ones that I thought were pertinent to our discussion on long COVID. But yes, it's a great multidisciplinary approach to health promotion and wellness, and just lifestyle-oriented primary care within the Live Well centers. So we encourage everyone to check it out.
Great. Thanks for sharing that. And Josh did say that answered his question. Let me see here. Yep. And that was just Josh saying thanks as well. It doesn't look like we currently have any other questions, and I know we're just over time. So I don't know if you have any last thoughts, parting comments you'd like to share with us, Liz or Dixie. Otherwise, we really appreciate the lecture. It was wonderful. And I'll turn it back over to the two of you for any last words of wisdom.
Dixie, any thoughts that you want to share with the group before we depart for the evening?
Yeah, I mean, this is what I tell the patients, and I saw 3 long COVID or chronic COVID. We don't even have a definition for this yet, but I just tell them we're all learning together, and we as doctors are listening to them and learning together. And that's why Liz talked about being on the Facebook site. It's been very helpful learning and hearing what our patients are telling us. So it's a very humbling process since we don't know a lot right now.
And we did have one other, I'm sorry. I was saying we had one other question come in. It says, is there any data about long COVID in pregnant women?
I have not seen it, but I have been involved in some long COVID after pregnancy. One woman who delivered, and she's delivered like 6 weeks ago, and still has this, everything smells like rotten meat, and she's very distressed by that.
Well, thank you. I don't see any other, oh, wait, let's see what just came in. They keep popping in. Oh, she just said thank you. So I don't see any other new questions in the chat. So thank you both. I don't know, Liz, if you were going to say one last thing.
Nope, I'm good, thanks. Thanks, everybody, for joining us tonight.
Yeah, thank you. Have a great evening.
Thank you.
Bye.
Bye.